Check the hands for clubbing, tobacco staining, coal dust tattoos, or other conditions which affect the hands and may be associated with lung disease, such as rheumatoid arthritis. Look for nodules or systemic sclerosis. Feel the pulse, and if it is bounding, or if the patient is cyanosed, check for flapping tremor of the hands due to CO2 retention, or a fine tremor due to beta agonist therapy, for example, salbutamol or terbutaline. If there is doubt about the presence of cyanosis, you could at this point check the tongue and the buccal mucous membranes over the premolar teeth before moving to the neck to look for raised venous pressure, cor pulmonale, or fixed distension of the neck veins, which could be due to superior veno-caval obstruction. Next, examine the trachea. Place the index and ring fingers on the imbrium sternae over the prominent points on either side. Use the middle finger as the exploring finger to gently feel the tracheal rings to detect either deviation or a tracheal tug, i.e. the middle finger being pushed upward against the trachea by the upward movement of the chest wall. Check the notch cricoid distance. Feel for lymphadenopathy, which can be due to carcinoma, tuberculosis, lymphoma, sarcoidosis in the cervical region and axillae. As the right hand returns from the left axilla, look for the apex beat, which is difficult to localize if the chest is hyperinflated, which in conjunction with tracheal deviation may give you evidence of mediastinal displacement, which is due to collapse, fibrosis, pneumonectomy, effusions, scoliosis. Look for asymmetry. Rest one hand lightly on either side of the front of the chest to see if there is any diminution of movement, such as due to effusion, fibrosis, pneumonectomy, collapse, pneumothorax. Next, grip the chest symmetrically with the fingertips in the rib space on either side and approximate the thumbs to meet in the middle in a straight horizontal line in order. To assess expansion, first in the inframammary and then in the supramammary regions. Note the distance between each thumb and the midline, which may give further information about asymmetry of movement, and between both thumbs, and try to express the expansion in centimeters. It is better to produce a tape measure for a more accurate assessment of the expansion in centimeters, comparing both sides at each level. Percuss the chest from above downwards, starting with the supraclavicular fossae and over the clavicles. And do not forget to percuss over the axillae. Few clinicians now regularly map out the area of cardiac dullness. In healthy people, there is dullness behind the lower left quarter of the sternum, which is lost altogether with normal level dullness in hyperinflation. Complete palpation by checking for tactile vocal fremitus with the ulnar aspect of the hand applied to the chest. Auscultations of breath sounds should start high at the apices, and you should remember to listen in the axillae. You are advised to cover both lung fields first with the bell before using the diaphragm. If for no other reason, then this allows you a chance to check the findings without appearing to backtrack. In the nervousness of the examination, harsh breathing heard with a diaphragm near a major bronchus, for example over the second intercostal space anteriorly or below the scapula near the midline posteriorly, may give an impression of bronchial breathing, particularly in thin people. Compare corresponding points on opposite sides of the chest. Ensure that the patient breathes with the mouth open regularly and deeply, but not noisily. Auscultation is completed by checking vocal resonance in all areas. If you have found an area of bronchial breathing, the sounds may resound close to your ear, agophony. Check also for whispering pectillorokoi. The classic timings of crackles, crepitations of various origins are early inspiratory, which is, for example, due to chronic bronchitis and asthma, early at mid-inspiratory and recurring in expiration, bronchiectasis, which is altered by coughing, mid late inspiratory, which can be due to restrictive lung disease such as fibrosing alveolitis and pulmonary edema. To examine the back of the chest, sit the patient forward. It may help to cross the arms in front of the patient to pull the scapulae further apart and repeat steps. You may wish to start the examination of the back by palpating for cervical nodes from behind, particularly the scalene nodes between the two heads of the sternocleidomastoid. Though with sufficient practice, this whole procedure can be performed rapidly without loss of efficiency. Often in the examination, you will only be asked to perform some of it. Usually examine the back of the chest. As always, when forced to perform only part of the complete routine, be sure that the partial examination is no less thorough and professional. So be prepared to put on your wide-angle lenses so as not to miss other related signs.